So, thank you all for joining us for our webinar today as part of the Cambridge Festival. Apologies for those expecting to see our trustee Mike Napton chairing this. Unfortunately, he's not able to make today's talk. So I've stepped in very last minute, and apologies, I will be reading from a script, so I hope it's okay. So my name's Claire. I've been at Addenbrooke's Charitable Trust for quite a few years, and I've actually helped fundraise for some of the work that we're hearing about today. Before we start hearing about that, I'll just run through today's housekeeping. So today we're hearing presentations on research into COVID-19 that took place at Cambridge University Hospital's NHS Trust, otherwise known as Addenbrooke's. We'll be hearing from our researchers, and that will be followed by a Q&A session. We're recording the event, and we've also got our Zoom subtitles up and running for this. They're not perfect, so do apologise any strange words. Submitted questions we will cover off at the end. However, please feel free to submit questions live through the Q&A function, but we might not be able to get to all of those at the end. So I'll just tell you a tiny bit about our charity. So Addenbrooke's Charitable Trust is the charity for Addenbrooke's and the Rosie Hospitals. And to support the hospital, we launched our emergency appeal early in 2020. And we raised close to £2 million for that emergency fund. And that funding helped provide staff sanctuary spaces in COVID areas such as A&E, critical care and theatres, provided health and wellbeing packs for staff to help fight fatigue and also the pressure sores from wearing full PPE constantly, along with providing access to psychological support for all. Our biggest focus through that time was COVID research. And to date, we've funded over 18 COVID research projects, and one of which we're hearing about today. And that's looking at understanding the long-term effects of COVID. Before I hand over, I just want to say that actually none of that work would have been possible without the wonderful support of our supporters in terms of their donations and their fundraising. They create our community supporting the hospital. Thank you all, and it really does make a difference. So, to kick off, I'm delighted to be able to introduce you to Professor David Menon. David was the first director of the Neurocritical Care Unit at Addenbrooke's, where he established the recognised programme for specialist critical care in the UK. And David's talking as one of the researchers working on that ACT-funded grant. And he'll be talking through this phenomena, the new phenomena of long COVID. So David, over to you. And if you could tell us a bit more about how the clinical service coped. You're on mute.
Thanks, Claire. And thanks to ACT for all the support that you've provided for our research, and indeed for the well-being of the staff members in the critical care services over the pandemic. So I thought I'd talk a little bit about two aspects of this, the critical care service and how we coped with the challenges of the pandemic, and then the research that ACT has funded and how it fits into the broader scheme of research. So let's just go and share. So let's talk first of all about the critical care surge at Addenbrooke's, and any of you who've seen the news would have realized that intensive care units around the country have expanded their capacity, but this capacity expansion phrase is rather complicated, because when you unpick it, it includes many components. So there's planning of the expansion, all of us sitting around at a time when you didn't need masks, as you can see, trying to work out how the different units are going to work together, deciding how we downscale other activity, understanding the ethical frameworks within which we do this, because you can imagine all the patients with cancer, the patients with acute illnesses in the peripheral hospitals that we serve as a specialist center, those people being referred to Addenbrooke's and having those referrals reduced had to be balanced against the demands of COVID. We had to integrate new technology, the whole host of new machines that came along, and this is the intensive care clinician, both nurse, doctor, and other staff as a technologist, expanding the staff base, because experts like this nurse here are few and far between, and we had to expand the staff base to staff the units, train these staff, getting all of the information that comes through in a busy intensive care unit and collating it, which requires a huge amount of experience and intellectual input, realizing that the patient is not just the disease, that patients have their own fears and worries, and really perhaps the most important thing you can do in certain circumstances is reassure them that they're going to get better, or when they're not going to get better, reassure them that you're by their bedside. And our nurses did a fantastic job doing this. Caring for the family, this we did find stressful in the families, even more so, not being able to talk to them face to face and having to give them updates on the phone, sometimes giving them very bad news, and they not being able to come and see their loved ones at the last hours of their life. This turned out to be relatively stressful for many staff, and we needed to make sure we cared for our colleagues. And though we concentrated on what was happening in Addenbrooke, because we were a referral center, we also cared for the wider community in the east of England and accepted referrals from smaller hospitals which had less flexibility to expand their service. And all this time, we were assimilating new knowledge about a disease that we had never seen before and trying to fit it into our conceptual and intellectual frameworks for intensive care as a general endeavor. And very importantly, we had to deal with the non-COVID ICU need. And we hear about computer viruses resulting in a denial of service. They just bombard the network with all kinds of queries, each of which in itself is not particularly harmful, but by their sheer volume, they result in paralysis of the network. And we needed to make sure that COVID wasn't denying service. A real virus now, not a computer virus, wasn't denying service for other diseases that we had to care for. So how did we cope with this? Well, critical care beds are conventionally classified as level 3 ICU beds, which typically have patients who are on a mechanical ventilator or have kidney failure and require one-to-one nursing. And level 2, which are high dependency. They have single organs failing. Usually they're breathing for themselves. And you can have a nurse-patient ratio that's a bit more relaxed, 1 nurse per 2 to 3 patients. So what happened with the surge? We used to run 2 units. One was general transplant and hepatology and other local specialist units, and a neurotrauma and trauma unit. And this specialist service across the 2 units is for about 4 million people in the east of England. At peak surge, we increased to 5 separate units, including these local services, the specialist services, and COVID-19 patients. Our ability to take care of ventilated patients was expanded from 37 to 104 beds, so more than doubled, nearly trebled actually. And the average number of monthly admissions went up from 170 per month to 270 per month. And in January of this year, it peaked at 377 per month, which is more than 10 extra patients per day coming into intensive care. And when we normally have, if you see here, about 6 patients, this is a huge increase that we had to deal with. And this clearly created challenges in terms of staffing, in terms of geography, because these units were not located close to each other. Some of these were in the operating theaters and the recovery areas, and being able to staff and coordinate all of these was a challenge. As I've already talked about getting additional equipment, I mean, there was a lot of noise made about getting additional ventilators, but the resource that's really limited is the staffing, particularly those of experienced ICU nurses. And then consumables, we were using drugs in far greater quantities, PPE, ventilator circuits. And the logistics of doing this was not easy. So how did we cope? Well, we had increased contribution from existing staff. There were over 3,000 extra shifts in just January and February alone. Research, supervisory, educational, operating theater staff, and other specialist staff were redeployed to patient-facing activity in the ICU. And a critical care task force was created, which consisted of medical staff from other specialties, general practitioners, medical students, dietitians, and military personnel. And these people came along and just helped with the manual parts of intensive care, the background work, making sure the results got tabulated, that observations were put into the electronic record, that patients could be turned because there were enough bodies amongst the clinical staff present. And these included some of my consultant colleagues. And we're eternally grateful to those people who came along and gave us a hand. And finally, we had exceptional operational management. And I'd like to give a shout out to Colin Fannin and Jane Owles, who are ICU nurses, but really lead the service. And without their organizational capacity, we would simply not have been able to cope. It's conventional for politicians and the press to say how wasteful management is, but for us, without these people, we simply would not have been able to take care of the patients that we managed to take care of. So that was clinical service, and I think we were lucky in Cambridge because, first of all, we managed to stay ahead of the curve, and we were never overwhelmed, for example, as you may have seen on the news bulletins that came from Italy, and not even stressed to the amount that some London hospitals were, and some of our local hospitals with smaller sizes were. But we had a very important other part to play, and that comes from a quote that's attributed to this man who's wearing an Elizabethan ruff. And when I looked at it, it looked like some antique version of PPE. But this is actually Sir Francis Bacon. And this phrase, scientia potentia est, knowledge is power, has been attributed to him. And in this context, knowledge indeed was power, because the research that happened really at breakneck speed, unbelievable speed, has improved our ICU outcomes over the last year. And we have a 10 to 15% reduction in expected mortality. And that means that between 1 and 2 of each 10 patients who came into the ICU and would have been expected to die at the start of the pandemic are now alive because of science. And this involved the recognition that later severe disease is largely due to the host response to infection, not the virus itself, because the disease itself is both the infection and how the body responds to it. So while antiviral drugs are helpful perhaps in the very early stages of the disease, steroids and anti-inflammatory drugs, which actually damp down the host response, are really beneficial later on. But it was also substantially due to better organization and delivery of critical care. And intensive care is a rather strange thing. There's no one thing that makes patients better, but there are lots of little things. If you don't do right, you can make patients worse. So doing these lots of little things very well is really important. And despite this reduction in mortality, we have a continuing high mortality, which is over a third of patients. So we clearly need further work to improve these acute outcomes. But that's not what we're talking about today. We're talking about a new problem with the aftermath of the disease. And a recent article in the British Medical Journal, looking at nearly 50,000 admissions, showed that there was a 29% readmission rate up to 6 months afterwards. And 12% of the people who had been discharged from hospital actually died after they'd been discharged. Now, this is a little difficult to interpret because the people who got COVID, particularly in the first wave, very often were quite sick to start with, quite frail, and it would not be unexpected if some of them died. But these mortality rates were in excess of what was expected. Perhaps more importantly, for what we're going to talk about today, if you take mild non-hospitalized disease, and I put mild as a qualified term, 21%, the Office of National Statistics survey recently showed that 21% of people are still symptomatic at 5 weeks after such mild disease. So this is a problem that we need to deal with. Now, we can deal with this in one of two ways. We can look at large numbers of patients and as a consequence of that, be able to see how people do. But we in Cambridge have decided to concentrate on mechanisms. So we have sick patients in the hospital who have low blood pressures, poor oxygen levels, their lungs and heart are not working. Their immune system is dysregulated, up in some ways, down in others, and you have an inflammatory storm. And you may start developing autoimmune responses. The immune system attacks itself. You may get neurological damage, which can either be overt, you see it on a scanner, or you might have to measure things on the scan to find out what it is. The period of long ICU stay with all the drugs and the immobility that's involved can add to this. And there are a whole range of psychological stresses. And this leads to the late readmission and mortality, the persistent severe disabling fatigue, arthritis, arthralgia, heart and lung problems, this brain fog, the brain fog that's been described, and the psychological and psychiatric problems, the residual neurological sequelae, the muscle wasting and nerve damage, and all of these problems. These are very similar to critical illness, but what is strange is that we're seeing similar symptoms in mild infections. And the work that we're doing with the money that's been provided by ACT has focused on two varieties of long COVID, the sequelae of severe COVID-19, all the patients we see in the ICU, and the symptoms after mild infection. And we focused on the mechanisms. We've used MRI to look for visible changes, special versions of MRI, and these shows the cabling between the different parts of the brain using a technique called DTI. And then the connection between different parts of the brain in terms of its activity with functional abnormalities. We're doing neurocognitive and mental health assessments, looking at heart and lung function, immune function, whether the body is mounting an immune attack on its own tissues. And as Ekpemi will tell you later, looking at what happens with the airway. I'll finish by just acknowledging the huge team of people that have made use of the valuable research funding that has been provided by ACT, and the people who have been picked out in red are the people who are running or being involved in research in the long COVID clinic. Rowan Bernstein, my ICU colleague who's running and organizing much of these services, Dot Chatfield, who's working in the research clinic, Joe Outram, who's the coordinator for much of this clinic, Ed Needham and Steve Saucer, who are neurologists, Ekpemi, whom you're going to hear from, Nyari Sitool, who's one of our infectious diseases consultants and is leading this clinic, organizations in Cambridge who are really co-focused. And finally, the thing that ACT has done is allowed us to have external collaborations. And because we were ahead of the curve in research terms, these external collaborations have allowed us to provide pilot data and play a really important part in national research. I'll stop there.
David, thank you. Wow. So David's painted a picture showing us how the brain has responded to the virus and what those effects are on our physical and mental health. And for one of the areas that we had not necessarily expected to be affected by the virus was senses, the sense of smell in particular. Initially, I think we all read and heard about the impact not being able to smell and how that was a symptom of the virus. And later, as we shall hear, the patients of long-term ventilation also had problems with their senses, swallow, smell, etc. So I'm delighted to now be able to introduce our second speaker, Miss Ekpemi Irune. Ekpemi is a consultant laryngologist at the hospital. She's also head, neck and thyroid surgeon at the hospital and runs a multi-speciality long COVID clinic together with speech and language therapists. So Ekpemi, apologies for that stumble. It'd be great if you could tell us a bit about your research.
Thank you. Thanks very much. That's all right. And of course, always fantastic to hear Professor Menon talk and about the sterling work that the team, our ITU team, did to get us through this pandemic. They were really at the forefront. As an ENT surgeon, it became very evident to us, to me and my colleagues, that we were going to have to play our part here. Certainly one of the important things about stepping ITU patients down into the peripheral wards and their ongoing care has to do with doing a procedure called tracheostomy. And that means creating a hole in the front of the neck in order to do that and getting them off the ventilator. And we needed a big team of people to do this. And they had an ENT team were able to mobilize to do a lot of that work along with our tracheostomy nurse team. And based on that, we realized patients will develop swallow and voice problems from that. But looking back, even prior to the ITU work that was being done, was getting an appreciation for the fact that a large component of patients with COVID-19 who were not coming to hospital to be admitted to ITU were presenting with loss of sense of smell. So yes, there was this very important part of the COVID-19 disease process, which required admission to hospital and ITU involvement, and that also necessitated the input from the ENT team. But before all of that, and in the background, there was a huge group of people in the community who were having problems with their loss of sense of smell. And actually, eventually, the World Health Organization and Public Health England began to recognize that loss of sense of smell was a very integral part of having COVID-19. And it became a very well-known symptom. I'm going to share my screen very quickly with you, and I hope you can see that. What we did was set up a study, which we call the Odyssey study, which looked at the assessment of sense of smell. When you think about sense of smell, people often think only about my ability to smell a cup of coffee or enjoy the smell of my child's hair or freshly baked bread, for example. But sense of smell is actually more extensive than that. It is how you tell whether or not you smell, whether you're clean, whether your clothes are clean, whether your socks smell. It is a very important part of feeling healthy as well. We have patients who present with acute sinusitis, and one of the ways they know they're having an exacerbation of their illness is they can smell the infection inside of their nasal passages. It gives people a sense of safety. So for example, how do you tell that you don't have a gas leak, and how do you tell that there's smoke, which indicates fire? It's by your sense of smell. And as I said, it's a very integral part of enjoyment of life, from food to relationships between partners or parents and their children. And a lot of people will say, oh, the sense of that smell, the smell of those flowers take me back to a time in my life, for example, or reminds me of my mother, or situations long gone by. So therefore, your sense of smell contributes to fear, uncertainty, your mood, and it can be very isolating when you lose your sense of smell. Your appetite is changed with a loss of sense of smell. You don't enjoy food that much. And if you can't enjoy food that much or enjoy the things that make you who you are, it affects your ability to interact with other people. It contributes to low mood. And when you have low mood, that can sometimes lead to depressive symptoms and overall an impaired quality of life. So we set up a study to objectively measure sense of smell. And we've been recruiting and are still recruiting patients who have had COVID-19. And here what we do is we invite people who have had the infection, who have had a positive COVID test, to come on board the study. And you do this by sending us an email, or by patients who have been through the hospital who we already made contact with through the massive COVID-19 research nursing service. Everybody who's recruited onto the study gets a tool to test their sense of smell, which is a scratch and sniff booklet that has lots of little capsules with little scents trapped within them. So you get a booklet with, for example, on one of the pages, you could have a capsule that has the smell of cloves trapped in it, and you use a pencil to scratch it, and it releases that scent, and you smell it, and you pick from an option of 4, and you may get within that option choices such as this is cinnamon, cloves, turmeric, or brown sugar. So these are scents that all kind of smell similarly, but we are looking for you to pick the correct option. And you also get a set of questionnaires as well. You get 2 questionnaires that test how your sense of smell is impacting on your quality of life and your enjoyment of life, and how much it's adversely affecting your mood, for example. You complete those questions, the 2 questionnaires, and you send them in to us in an addressed envelope that's provided. And we send these out to you the first time we make contact with you, and we send them also at other time points for a whole year. by looking at this information so far, the good thing is we know that patients who have had problems with their sense of smell are getting better. There's still a lot of work to do because we have a lot of patients who still have ongoing problems with their sense of smell. And so we know that there will be a spectrum of people and a variation of recovery. With regards to benefits, you can imagine that this study allows us to understand how the virus works, and it allows people who are in the community who deal with patients, such as general practitioners or specialist nurses, advise patients properly. So hopefully at the end of the study, we'll be able to say, this is how long it usually takes on average for your sense of smell to get better after COVID infection. It will also allow us to create guidelines that will stop people undertaking unnecessary investigations in patients who have had COVID that still have problems with the sense of smell. It will allow us plan skill sets, whether or not we need additional technology, and it will allow us to accommodate surge strategies for patients who do eventually develop COVID-19 at a later time, for example. The key thing here is the impact on health economy. If patients' expectations aren't met, they tend to use GP services more. They tend to come to hospital more. They tend to require more scans, more hospital intervention, and therefore there appears to be often and is in actual fact a diversion of services to look after those patients, because there's only a finite number of resources. But if you can tell patients what to expect, the outcomes are often better. If I can tell you it's likely to take X number of months, your mental attitude towards that disease process is healthier. You're more likely to be in a better mood. You're more likely to have better quality of life. You're more likely to be less dependent on healthcare, and you're more likely to return to work and your activities of daily living sooner rather than later. Now, one of the things that Professor Menon mentioned was the work that we had done on swallow, voice, and upper airway. Now, we know that patients who have been in ITU for other things that are not related to COVID do develop swallow and voice and upper airway breathing problems as well. But we also know that in COVID-19 patients, this appears to be pretty profound. And therefore, it became obvious to us in ENT that even after the COVID pandemic settled, we may be left with a large amount of patients who have ongoing swallow, voice, and upper airway breathing problems because they have been in ITU for so long with assistance to help with their breathing, and also just the impact of the disease and the infection on these mechanisms. You can imagine if you're in ITU, you're not swallowing, you've got to feed, you've got a tube that's helping you feed, you've got a tube that's helping you breathe, and all of these things get inflamed. They're not being used, so the muscles become weak. And so we set up a joint COVID clinic to look at these problems with a speech and language therapist and our tracheostomy nurse services, specialist nurse as well. And together we're able to see patients who come in, who have been in ITU. We do endoscopic procedures to assess their voice. We undertake swallow tests, seeing how they swallow liquids, solids, semi-solids as well, and to see whether or not they have problems with the muscles that help them to do these things. And then we offer them rehabilitation. And we're finding that on the positive side, a lot of patients are getting better, but there are still patients who are struggling to speak properly, to go back to work. And it's quite important for us to continue to do that work. We're very lucky to be able to do this. And the one thing that has been important is with the resources we have, we're not just diagnosing these issues, we're able to offer rehabilitation as well and treatment where necessary. And we couldn't have done that without the grant from the Addenbrooke's Charitable Trust. So to finish, to conclude, we're very lucky to be able to have ACT and to work very closely with them, to have the support that we get from them, and also from our medical colleagues. A lot of the work we do is collaborative. And that's the only way we are able to achieve the outcomes that we can achieve. COVID-19 is not just an event, it's an entire journey that has long-term impact on quality of life and survivorship. And the work we do allows us to be able to mitigate these consequences. Thank you very much for your time.
Goodness, thank you so much. Thanks to both David and Ekpemi. Both absolutely fascinating, and I'm sure people have got questions. So if you'd like to pose a question now, that's absolutely fine. If you use the Q&A function, we'll get to those. We might not get through them all. Quite a few have been submitted already. So David and Ekpemi, are you happy for me to pose some of our questions?
Yes.
Brilliant. Actually, looking at them, some might have been addressed in your talks already, but I'll scamper through them and we'll see how we get on. So question number one was, when did you discover there was such a thing as long COVID?
So I think it's important to say that we should probably have expected it, particularly for the most severe patients, because we know that of the patients who come through an ICU, about 30% of them, for example, have cognitive dysfunction, what might be described as brain fog. This is before COVID. And the other COVID-like illnesses we've had in the past, such as SARS, which didn't affect us, luckily, and MERS, have had neurological complications before. So we should have expected it. But really, it was sort of 3-6 months into the pandemic that we started realizing the magnitude of it. And really, the knowledge of that has grown. As I said, the Office of National Statistics had published just yesterday, might be the day before. You lose track of days with COVID. It's one of the problems, that 1.1 million people in February were suffering from long COVID, which they defined as people having symptoms at least 5 weeks or more afterwards, after the acute illness. And a lot of this was in patients who had relatively mild illness. So our knowledge is increasing all the time, and we are really getting a really good handle on the epidemiology. How many people have it? What sort of people get it? What we don't have such a good handle on as yet is the mechanisms of disease. And as I said, scientia potentia est. Once we have that knowledge, then we can look for treatments.
With ENT, with the knowledge that, like Professor Menon said, patients who have already been in ITU do develop problems, we realized that we would have a surge of patients who, even after their hospital admission, will continue to have swallow and voice problems. And so we started to think about how we could manage those patients on top of our normal workload. So for us, that came a couple of months into realizing the volume of patients that we're going to be seeing in the hospitals and coming up into ITU. And with regard to the sense of smell, that work really, and that knowledge really came from the work that was done by other colleagues in different parts of the world. And so that was very helpful for us, and again highlights the importance of collaboration. And during the pandemic, especially in the early days, my colleagues and I will tell you, we have never consumed so much information. We were reading research papers and information being supplied from colleagues across the board at the speed of light. I mean, every day you would read up to 3 or 4 research papers. We also had a mechanism within the scientific community where papers and research information was being released very early, really rapid, pre-peer reviewed papers. And I think that really allowed us to be able to appreciate some of the potential consequences of COVID.
Fantastic. We're actually getting some questions coming through as we go, so I'll cover those off now if that's okay. So one of the questions was, have studies and research shown that inhalers are effective in helping individuals breathing?
I'll mention this briefly. So generally the inhalers that we use for asthma are for conditions where there's constriction of the airways. And in asthma, the smooth muscles around those airways constrict down. And there is some element of that, but the vast majority of the abnormality in getting oxygen into the body and getting carbon dioxide out and not being able to do exercise is because the lung tissue itself is not transferring those gases very well. So there isn't a huge benefit from the inhalers. Certainly nothing published that suggests it would be a big difference. There are some patients who have an underlying tendency to have asthma-like disease, and there I think it may make a difference because any infection can make the airway much more irritable.
From an ENT perspective, our use of inhalers has not changed. So for example, we get a group of people who get a cough, and the cough has to be specifically because of what we call laryngeal hypersensitivity, which is when you get an overexcited voice box that gets easily irritated. So that's not a new diagnosis. And our use of certain inhalers such as tiotropium, something called Spiriva, for example, has not changed. And the only thing that has changed is we've seen a larger proportion of patients with laryngeal hypersensitivity because of COVID-19. And so our use of inhalers in that situation has not changed.
Okay, thank you very much. On to the next one. What are the medical treatments available for long COVID? I mean those that can be delivered in primary care. I guess there would not be sufficient resources set up and to run MDT clinics for a huge number of populations. Is there anything a GP can do?
So specific treatments, where we know what the pathology is, then there is a chance for us to employ treatment. So there is a new study that's just been approved called HEAL, which is actually coordinated from Cambridge. It's run by two of my colleagues, Charlotte Summers, who's an intensive care colleague, and Mark Toshner, who's a respiratory physician. And HEAL will provide a platform for looking at studies where we start treating patients who are being discharged from hospital with interventions to prevent late complications. So the first two likely interventions in HEAL will be blood thinning agents, because one of the things that COVID does is makes the blood much more sticky and can cause clotting in blood vessels. And when the next wave or the next set of patients come through the system, one of the drugs that might be used is a low dose of a blood thinning agent to try and prevent this late clotting. And maybe some of the symptoms that we see afterwards are because there's clotting, and these clots can break off and go to the lung. So there are some specific mechanisms, but for the patients who turn up after a mild illness and come to the clinic, we're still grappling with understanding, as I said earlier, the mechanisms of disease. There are some treatments that are being proposed, but we don't have good evidence for them. But because we don't have specific treatments, doesn't mean we can't treat people. And I think general practitioners have a wealth of knowledge and the experience of treating with many other conditions. So just general improvements in health, graded exercise so that people's fitness increases, dealing with mood, referral to the so-called talking therapies for psychological stress, IPAT and so on, are all tools that are available. And the point that Ekpemi made was, we're learning so fast with this disease that even in 3 to 6 months from now, I think we'll know much more about what we should be doing for these patients than we know now. So there is a lot of individual things that are under investigation, none of them proven, but the general care can certainly make a big difference to patients.
Thank you. Certainly from an ENT perspective, sense of smell training does help. There's certainly been a study that shows that it's one of the beneficial things. So as a GP, you can invite your patients to undertake smell training. Well, first of all, tell them about the Odyssey study that's happening at Cambridge, and we can always make the email address available to you all. And the other thing, of course, is there is a charity called Fifth Sense, and on there they have put together a very fantastic package that tells people about how to undertake smell training. And what they do is all about supporting patients who have loss of sense of smell. And until you lose your sense of smell, you cannot begin to imagine the overwhelming impact it has on your quality of life. So I would recommend that for sense of smell. The second thing is to be aware that patients who have a clear history of loss of sense of smell after COVID-19 do not require scanning. So try not to necessarily send them off for an MRI scan. That just adds more impact on the healthcare environment within which we're working. But of course, if you are suspicious of something else, then send them to us in ENT for an outpatient appointment. With regards to patients who have ongoing voice and swallow problems, we run the joint COVID clinic that looks at voice and swallow issues, where we can objectively investigate and offer rehabilitation. Again, please refer them into ENT so we can manage these issues. And as Professor Menon has already said, it's so important to manage these patients' mental health, and a referral to mental health support, is very important, because that will influence how they respond to any other physical symptom we try to manage.
Thank you.
I should perhaps just add, Claire, that there are 2 clinics conceptually running. One is a multidisciplinary clinic for hospitalized patients, and those patients are screened by the clinic team. But there is also a long COVID clinic. As someone said in the list of Q&A, I mean, we would be overwhelmed if every patient came our way, but clearly if there is a problem, then a referral to a specific problem, then a referral to the infectious disease clinic run by Neurosciences would be very appropriate. Have to be careful that we don't overwhelm services. In terms of research, all of these clinics are seamlessly marrying together clinical care and research. And the patients who come to us with long COVID are hungry to find an explanation for their symptoms. And then even if they can't treat it, just understanding is an important first step. So we are trying to not just help the population of patients, but in my experience, not just in COVID, but across doing clinical research for 30 years, is that making a patient a participant rather than a victim of the disease, a participant in the research, means that they become another soldier in the war against the disease. And that makes it something that they have control over. So yes, we welcome research participants.
I'm actually going to jump to this question, which is how are you communicating, disseminating the results of your research to colleagues in other hospitals? I don't know if Ekpemi wants to take that first.
Yeah, so for intensive care, there are 2 large communities of clinicians who get together. It used to be on a weekly basis during the acute part of the pandemic. And even though the literature was coming out really quickly, sometimes you just needed to talk to your mates in other hospitals and say, what did you do with a problem like this? And we were getting together, and it was as though you suddenly had the chance to talk to consultants from a huge community. And God knows COVID's had very few advantages, but that dissemination, that community of care, I think was very useful. It's less frequent now, but it's happening probably once every 2 to 4 weeks. But those 2 fora provide us with an ability to discuss findings. More recently, the Shelford group of hospitals, which is the 10, 15 hospitals that sort of have very strong research links, had a discussion about how we would deal with some of these late COVID problems. And those will happen from time to time when there's a more focused discussion.
The Royal College of Surgeons of England have a COVID research group that's made up of researchers, clinicians all over the country who dial into this group. And so we're able to exchange information that way. And actually on the website, you can log on and see the list of research that's running. And if you want to support that, you can go in there and join one of those research projects going on. And the second thing is the Odyssey study, the smell study, is actually a multi-center study that's running here in Cambridge. We being the main, the sponsor and site, supported by ACT, of course, but that's also running in other parts of the country as well, including Imperial in London and Cornwall Hospital. So really trying to look at different demographics of patients. And of course, as Professor Menon says, as individuals, we're communicating to make sure that we are all exchanging information. And these days, when you want to start any research in COVID, you can go onto the NIHR websites and you can look and see what's already there, so that you're not duplicating work, and so that you can also collaborate effectively as well. So there are many ways in which we're keeping in touch with each other.
Brilliant. So I think we've got about 8 or 9 minutes left. So I'm just going to see if we can cover 1 or 2 questions that have been left. So Ekpemi, if I start with you, I know you talked about Addenbrooke's as it goes through the peak of the virus. The question is, how are things in the hospital today, and what is the scale of so-called long COVID within the hospital? Are there now more long COVID patients than COVID ones?
So that is a loaded question. That's it's not very easy to answer because while we work collaboratively, to some extent, we also sometimes work in silos. So certainly, I'll let David Menon tell you about what the situation is in ITU at the moment. But from what's happening on the wards, there's still a number of COVID patients in hospital. This is not yet what we will call long COVID. This is just the immediate consequences of having been in ITU, for example, or patients who were acutely unwell but didn't necessarily need ITU. So people are discharged from hospital as soon as they're safe to be able to go home. Our clinics now are full of patients who we have had to delay seeing because we were looking after COVID. Typically, within ENT, long COVID patients are dealt with on an outpatient basis rather than on an inpatient basis. And we're lucky, again, because of the ACT grant and also because of funds that have been set aside by Addenbrooke's hospital itself to be able to provide long COVID support to ENT patients, for example, outside of our business as usual work. So when you come into the hospital as a patient and you come into the clinics, you will be seeing patients who have things that you have if you're in a particular clinic, not necessarily patients who have long COVID. That will be what will happen if you come to ENT. And our hospital wards are full of patients who need operations for things like hip replacements and long-term problems or cancer. And they're also full of patients who are still recovering from COVID, but not necessarily patients who have long COVID.
Thank you.
So the intensive care unit's one of the first units to be hit, but what's happened is we're also one of the first parts of the healthcare system to actually ease off. So from having 10 plus patients a day coming in with COVID, it then became 10 a week after several weeks. And now it's all in single figures. And I'm on for the Easter weekend starting tomorrow for the neuro and trauma ICU. And I'm looking forward to going to a unit where there's no COVID for us, certainly. There are some in isolation rooms left over from the previous admissions. Fingers crossed. I don't know what's happened today. Someone's covering for me today because of this talk. But we have, as Ekpemi said, a huge backlog of care that we have to deliver. This is that denial of service story by this virus. And we just have to make sure that we actually deliver what we need for the larger population of patients and the wider spectrum of diseases that we need to care for.
Thank you.
Can I just say something that there's often a discussion about patients, but COVID has really affected the staff as well. So, and I think that's something that we mustn't lose sight of, from physically exhaustion, for example, to mental perspective. So there's a mental burden of having had to look after patients who have had COVID. And that is across the board, doctors and nurses, junior doctors to senior consultants and professors, and even management staff. A lot of people have had to roll their sleeve up and spend months and months doing things that they didn't necessarily imagine they would have to do. In medicine, when you specialize in an area, you do so because you have a passion for it. And being redeployed to do work elsewhere can sometimes take a toll. And of course, as healthcare providers, we've also had to look after these people who we really think very highly of our patients. But there's also been an underlying anxiety about taking COVID home to your loved ones as well. And so our mental health colleagues are not just having to look after COVID patients, they're having to also support members of staff as well.
Absolutely.
Some people are just getting the chance, the first time in a year, to take a couple of weeks off for themselves. Absolutely. So we're very grateful to work with such amazing colleagues.
Thank you both. I don't know if we're going to get time to do this question justice, but I'll ask it anyway. Is there any role for antiplatelets long term to prevent clotting sequelae post-COVID? And thank you all for doing and presenting such excellent work.
We don't know. The suggestion, so there are two parts. When you start bleeding, there are two things that happen. One is that the platelets, which are the cells in the blood responsible for initiating clotting, start off the clot, and then the proteins in the blood form the firm clot, and then it all stabilizes. The received wisdom is that we should be using the anticoagulant drugs, the ones that inhibit the blood proteins rather than the platelets. But antiplatelet drugs have had a wide spectrum of activity in many diseases, starting from stroke, going all the way up to some forms of cancer even. So they're very pleiotropic drugs that have many effects. So I think that it may wind up getting tested, but right now there's no evidence.
Okay, so I'm going to draw a line onto those questions, and thank you both so much for coming and chatting to us today. It's absolutely fascinating, and I'm sure we will have many more of these conversations as we hopefully move out of the crisis. So formally, I just want to thank the panelists for joining us today, and thank you for all those people who've helped us fund this work. We can't support clinicians like David and Ekpemi without the support of our community. If you'd like to find out a bit more about what ACT's doing, about what David, Ekpemi are doing, we've got some contact details on the slide. And I'm aware that we're closing slightly earlier, but thank you very much. And
if I could just say one thing, through this seminar and through ACT, I'd like to thank, first of all, on behalf of the large number of people I showed on my slide, ACT, and then all the donors who actually provided money for this research, because it allows us to stay ahead of the curve in research terms and have a substantial contribution to trying to make patients' lives better. So thank you very much.
Likewise. Right. Thank you very much.
Brilliant. Thank you very much. And I hope you will have a lovely Easter weekend. Thank you.
Happy Easter, everyone. Take care.
Bye-bye.